Good morning, ladies and gentlemen. Thank you very much, Claudio and the Scientific Committee, for the invitation back to Vicenza. It's always a treat to come and talk at this superb kidney meeting. My name's Andy Shaw. I'm an anaesthetist. I'm usually the only anaesthetist in the room at this meeting, and I assume I am today again, which is okay. I'm going to talk about a couple of trials we did over the last few years, which speak to the issue of what sort of fluid should you give to people who are unwell. Let's see. Okay. I don't have any relevant disclosures for this talk. I won't make any off-label comments. As you know, fluids don't really have a label. They were licensed and approved before labeling was a thing, and I'm not going to make any off-color comments either. I want to try and set the stage by giving you a sort of an estimate of why there's equipoise here. So here is some of the literature that saline is bad for you. Okay, I normally have this slide set up so that each paper comes one by one, but we don't have time for that. And so to illustrate why there's clearly, an imbalance here, why it's unclear what fluid we should give, here is the evidence that saline is good for you. Now, as you can see, when there's such an overwhelmingly balanced sets of literature, it's important to find the answer to how to find the answer to what type of fluid should you give, balanced or unbalanced. In Australia and New Zealand, there was a study done setting up a larger trial. That was the SPLIT trial run by Paul Young and colleagues, which demonstrated no apparent difference in dialysis rates, no apparent difference in AKI, and a small but non-significant potential mortality signal. And this was, in the words of the investigators, a pilot trial to see if it was feasible to randomize patients between balanced fluid and saline in the intensive care units. And they concluded that it was feasible, but everybody in the world was now pretty skeptical that finding a meaningful difference between the two groups would be easy. So this was a randomized clinical trial that flew in the face of a mountain of observational literature which had been amassed by people like me up to that point. Now, at the time, I was working at Vanderbilt, and we were also working on a similar interventional design, and we did this pilot trial, the SALT trial, where we explored within the Vanderbilt electronic medical record and learning healthcare system, were we able to allocate patients on a cluster crossover type basis. So this was that pilot trial. We allocated 974 patients in the MICU, the medical ICU, to either get saline or balanced fluid on alternate months. And that trial ran for a few months, and we found that we indeed were able to set the trial up and run it. And it turned out that from a results perspective, the primary outcome, which was MAKE30, and I'll talk about that in a minute, there was no significant difference. But there was a very tantalizing effect of dose. And you can see in this graph here, the further towards the right-hand side of the screen you get, the more fluid you've got. There's a clear separation between the saline group and the balanced group. And this was another criticism of SPLIT, and in that the exposure dose was very small and therefore unlikely to be able to drive a signal in MAKE. And I'll make some more comments about that in a minute. So we were pleased that SALT had worked. We demonstrated that we could use our electronic medical record to both allocate patients and measure their outcomes. And so we set these two trials up, SMART and SALT-ED. We published their protocols in trials well ahead of closure of data capture. And in fact, as well as publishing the trial protocol, we actually published the R code, and I'll come back to that slide in a minute. We actually put the R code for the final analyses of the two trials in the trials paper so that people could test it and see whether or not they were comfortable with it. So SMART and SALT-ED were a pair of trials that we designed to provide guidance on which is the best crystalloid to use in critically ill patients, both in the ICU and in the emergency department. And SMART is the ICU trial, and SALT-ED is the ER trial. And between them, they put a little over 25,000 patients were allocated to either receive balanced crystalloid or saline. This is the SMART graphic, and you can see... Is my arrow coming? No. Let's see if this is going to work. Okay. Well, you'll have to look at the colour boxes at the bottom. The rows are our 5 adult intensive care units that we had at Vanderbilt. Each one describes the type of patients admitted to it. The columns are individual calendar months, starting on the left with June 2015, finishing on the right with April 2017. And you can see that each ICU was randomly allocated to start with either saline or balanced fluid. And thereafter, every month, on the first day of the month, the unit switched over to give the other type of fluid. And this was all fluid for all patients. And our IRB gave us a waiver of informed consent to do that on the argument that both of these fluids are in widespread clinical use, and the day that you arrive to the emergency room or the ICU is fairly random. So this is not random allocation, but this is capturing the random arrival of patients at the hospital, which we believe is valid. Others believe is not valid. I will say that. But the important point is that by the end of the trial, half of the patients have been exposed to intervention 1 and half have been exposed to intervention 2. And this design allows everybody who comes to the hospital and ends up in the ICU or the ED to be included. So you don't get this selection bias for the very ill patients who can't provide consent. So we think this is a very powerful, real-world, pragmatic design that's specifically designed to capture very large numbers of patients in a relatively short space of time, which we think we did. Let's see. Here's the R-code thing. And these papers were published on February 27th this year together in the New England Journal. This was good for me personally because this was the very first day that I started my new job. And so I was able to call the dean and say, just a couple of papers in this week's New England Journal, you know, don't get used to it. So that was a nice little twist for me. So here, I'll tell you about these 2 trials now. Here are the intervention. Very simple, very straightforward. Is it better to get saline or is it better to get balanced fluid? And we used Plasma-Lyte and lactated ringers because we didn't want to try and get into that question in this trial, although I do think that's an important question that is still unanswered. Let's talk about SMART. The lead author for this is Matt Semler. At the time he started this, he was a fellow. He's now attending at Vanderbilt. Watch the name Semler. He is a rising star. Todd Rice is the senior investigator, and the Vanderbilt MICU group have been doing this sort of large-scale trial for a while now. The primary endpoint for SMART was major adverse kidney events within the 30 days, and I'm particularly pleased to hear Paul talk about some of the issues about prolonged MAKE and the other stuff that happens to drive it. The reason that we started to think about MAKE at 1, 2, and 3 months is because of criticism that short-term outcomes aren't relevant. Well, it turns out that there's 2 sides to that coin. So this outcome is MAKE 30. We're a little more specific than PRESERVE in that we require a 2 times elevation in serum creatinine in order to qualify for the worsened renal function outcome. But otherwise, it is exactly the same as PRESERVE. Here are the results for SMART. 16,000 patients or so admitted to our 5 ICUs. The allocation worked very well. There were 7,860 in the saline group, 7,942 in the balance group. And you can see the allocation is fairly equal across the 5 ICUs, but very typical of, we believe, of a large North American quaternary referral center. One of the things I think you need to decide is how similar does your institution look to ours for how valid or generalizable these data are. In terms of the 2 exposure groups, absolutely no differences at all between the demographic characteristics. About 1 in 5, 1 in 6 patients had CKD, which is important. And about 8-9% of patients at the time of presentation had stage 2 or greater acute kidney injury. Now, at first glance, this particular slide shows that there was good separation between the balanced crystalloid group getting predominantly balanced crystalloid and the saline group getting predominantly saline. And that's true. However, look at the volumes given. Very, very small volumes. In fact, the median volume of fluid given to these patients over the course of the trial was only about 1 litre, just a little over 1 litre. So Vanderbilt, clearly a very dry institution, and we accept that. And that is one of the main criticisms of this trial. The large dose of fluid question is not given, but I have a comment about that I'll make at the end. Despite relatively small total volumes of fluid being given, there was clear separation in the biochemistry. 35% of patients in the saline group became hyperchloremic and 20 to 25%, I think, in the balance group did. So separation in terms of biochemistry, how clinically relevant that is up to you to decide. The primary endpoint occurred more frequently in patients who were given saline than patients who were given balanced crystalloid fluids. P equals 0.04. And this delta is driven in SMART by death, not by persistent renal dysfunction or new RRT. And I'm perseverating on that a bit because that's different for SALT-ED, which I'll get to in a minute. Notice also the event rate overall, about 3 times the event rate in PRESERVE. Again, we think because of differences in severity of illness at enrollment. The odds ratio for the pre-specified subgroups, clearly statistically significant effect in sepsis, entirely consistent with the pre-existing literature. And TBI, there's a tantalizing switch in the side of the point estimate towards saline. Whether that's clinically relevant or not is unclear. As you know, there is debate about whether or not tonicity is more important than chloride content for people with sick brains. So overall, a number needed to treat of 94, 1.1% absolute reduction in death, new dialysis, or persistent renal dysfunction. Specific benefit in sepsis, be careful in traumatic brain injury patients. Okay, so what about the ED patients? This is the other paper published on the same day. The primary author here, Wes Self, a very talented emergency room physician at Vanderbilt. Same group of investigators were involved in both trials. This is very similar design, but only one cluster here, crossing over multiple times. This is the emergency department, the adult emergency department at Vanderbilt. The rules were, in order to get into this trial, you had to get at least 500 mils of isotonic fluid, and you had to be admitted to the hospital, not to the ICU. The primary outcome in SALT-ED was hospital-free days in the first 28, which effectively is a composite of in-hospital death and length of stay. If you died in the hospital, your outcome was coded as 0. Exactly the same outcome as SMART. And by the way, the outcome was assessment was automated within our EMR. We wrote some code that was able to pull out the outcome from the electronic medical record, which is important for doing these large trials. Good allocation, again, as in SMART. Half of the patients got intervention 1, half of the patients got intervention 2. A little over a total of 13,000 patients overall were included. Baseline characteristics, again, identical to each other. No significant differences. Again, clearly measurable changes in biochemistry. Saline patients had more hyperchloremia than balanced patients. Is a 2 millimole per liter difference clinically relevant? Well, maybe it is if you believe the results of this trial. Primary outcome completely negative in SALT-ED. No difference whatsoever in hospital-free days. But statistically significant reduction in MAKE-30 in SALT-ED patients, this time driven by the worsened renal function component of the composite, not by death. So you may say, well, why the inconsistency? We think it's because of the concept of competing risk and severity of illness at enrollment. SALT-ED patients, by definition, are not as sick as SMART patients, but are sicker than PRESERVE patients. So we actually think, this is the first time Paul and I have had a chance to present together on this, I think there's a lot to learn by looking at these 3 trials together, particularly about the significance of the MAKE endpoint and where we should go with it in the future. So an interesting point about the endpoint. So here is those comments depicted graphically. You can see similar increase in the incidence of MAKE-30, this time driven by persistent renal dysfunction. So here are the 2 trial results together. MAKE-30 in SALT-ED, overall about 5%. You've seen that number before. I think that's what Paul just showed you. SMART, about 3 times that in 15%. Statistically significantly better in patients treated with balanced fluids rather than saline, but for different reasons. In the less sick patients, less persistent renal dysfunction in the more sick patients, less death. Why was Smart and Salt ED effective? Why were we able to do this? A number of reasons. Firstly, these fabulous investigators, this is the Smart and Salt ED team, some of the smartest, excuse the pun, people I've ever had the pleasure to work with. The trial was EMR based. The trial was pragmatic. It got into a real world question by using real world scenarios. Our IRB gave us a waiver of informed consent. There's no way we could have done this trial if we'd had to to obtain consent up front. It was quite an arduous process, but it was worthwhile. The CRF was small and it did not have a bunch of extraneous data in that was collected in case we would find it useful. 25, not 35,000 patients. And Vanderbilt has this concept of the learning healthcare system whereby everybody contributes to the advancement of the specialty and the knowledge. So I think fluid is toxic is a little bit off message there, but give the least you need to get the job done. There's other data about liberal versus restrictive in this space right now. I do think high chloride solutions are not good for you. The evidence is pretty overwhelming now. Not all questions are answered. The mechanism is less clear. And I've just shown you two large trials in, we think, quite a lot of patients that would suggest that when you're making that decision at the bedside for which type of fluid to reach, you should probably reach for a balanced fluid first. Thanks very much.
Thank you very much, Andy.